And next, we're so pleased to introduce Fan Lee. Fan Lee is an associate professor of statistical science in the Department of and also in the Department of Biostatistics and Bioinformatics, excuse me. And she'll be talking about addressing healthcare dilemmas and disparities during the COVID-19 public health crisis.
Thanks. Everyone can hear me? Oh, okay.
Yes, we can.
Okay, so you can all see the slide.
I think that your slides aren't projected yet.
Oh, okay. Let me do it. Here we go.
There we go.
Okay. Oops. Okay.
Perfect. Thank you.
Okay, so thanks particularly to Tim's and Fred's previous presentation. I here really give a concrete example of what the partnership with CHC, the Change Healthcare, has been and has been helpful to our research. So, so this is just some background. This is respond to a PCORI COVID-19 emergency fund announcement. So we finished this grant last month with Len Thomas at the Biostatistics department, and I'm pretty sure many of you actually also apply to this grant. But so this is our, we are mostly focused on two research questions using the unique data set from Change Healthcare. So the first question we were thinking, most think is, previously in New York Times, there was a news title called "Where Did All the Heart Attacks Go?" So the story is, the fear during the pandemic, the fear of catching COVID-19 prevent patients from pursuing necessary care, even if it's urgent care, right? So, so then this is, so we really, this lead to our first aim. We really want to identify actually the evolving state and local level underutilization of inpatient and outpatient service for serious health conditions. Because we think this is very important, because this actually, if you look at the data about mortality, there's a lot of excess mortality during the pandemic, not specifically due to COVID, but more due to other things, precisely due to the underutilization of the healthcare services. So we think this is important actually to pinpoint, to find where those underutilization particularly be a problem. So that's our first question and aim. So the second question is the disparities. So really, we again read from Washington Post, the one thing stick out is that, okay, it's well documented that the COVID-19 affect minorities and the poor population more severely. And you can see that among the diagnosed patients, that the African Americans and Hispanics has a disproportionately high number. But what is really, what is even more troubling is actually most of the states do not release information about testing, like among the tested patients, how many people are the Blacks or are the Hispanics. So this actually could, so let's say in a scenario, if the African Americans are less tested and then they presented actually in a higher number in terms of diagnosed, that means the problem, the disparity problem, is even worse. So the key thing is we don't know that in most of the current public available data, we simply don't see that information. So this leads to our aim 2, which is quantify and monitor the racial differences in the COVID testing and outcomes, and identify communities and subgroups that require target intervention to eliminate or mitigate disparities. So again, Tim already gave a very good overview of what is Change Health data, Change Healthcare data. So for this particular study, we propose to use the insurance claim data. So it's a vast amount of data there, overall almost 120 million people. So our sample, we propose to use all or most of the health, the insurance claim data recorded by Change Healthcare between January 2019 to June 2021. So basically around 1.5, well, this is 2.5 years of worth of data. So this data contains two big groups. One is a private health insurance that account for 96 million of patients, and Medicare Plan C, Medicare Advantage, so 19. So these two groups are separated by age. The first is the private one below 65, and the Medicare Advantage mostly patients over 65. So the study design, what we're thinking is we're using, because we are to look at we want to look at the change. So it's important to also have a retrospective cohort, like what happened before the COVID-19 and what happened during COVID-19, and actually ongoing, because nobody know when the pandemic will really end. And so we want to do, so we do a retrospect cohort starting from January 2019 to July 20, next month. Hopefully that's the start of the study, and then we will monitor every week to monitor every week, and then to report our results. So again, this graph give you basically what we're thinking here. So I think I used my 5 minutes, so I will just use 1 minute to wrap up quickly, but you get the idea. So the key thing is in this big data set we have, then for the M1, in order to study the underutilization of healthcare service, then we can actually just look at, we basically can go to stratify by state or by the zip code, the 3-digit zip code, and then stratify also by age, by sex, and by race, the outpatient service encounter, the number of that, and inpatient service encounter. So that will give us idea, and then we will draw the spatial temporal graphs or maps to show that, to show and to pinpoint where the underutilization exactly happened. And then for the M2, which is a disparity, actually, again, because we uniquely have the Change Health Care data is uniquely have such a large amount of the test patients, then we can actually further go to a serious subpopulation, and we can actually look at, we can go into the tested patients and see that to see the racial decomposition there, and then we can among those tested patients we can go deeper into the patients who are diagnosed with COVID-19 and again see the racial decomposition there, and we can then also draw the graphical presentation of the state and ZIP3, and then among the diagnosed one, we further go to see the hospitalization, to see the different racial decomposition. So this will give us a much clearer, well, first the data, because the data is much bigger than any current study, so we have a much more global view, but also because we have how refined the data is, we're also able to have a very refined idea of the disparity lie in different levels. And in the end, we can also do some statistical analysis to build predictive model and to connect all of these outcomes to the social determinants and all the other census information about the different counties or zip level. So we just think that we can do a lot of things and do it on a real time and really provide good service to the provide important information for the policymakers and also to the medical community. Thanks.